Good morning. Today I will to talk to you about a very important topic in the field of dentistry and oral health. We will focus on the genomic, proteomic, and cellular mechanisms underlying the observations described in the article titled Restoration Survival Time is Shortening in Patients with Dry Mouth. This research highlights a significant clinical challenge, the decreased lifespan of dental restorations in patients suffering from cheostomia, that is, low or no saliva production. Saliva is an essential component of oral health, playing a crucial role in cavity protection, digestion, lubrication, and the overall health of the oral cavity. However, in patients with cheostomia, the lack of this vital fluid can have detrimental consequences for their dental health. Throughout this presentation, we will explore hypotheses about the possible genomic, proteomic, and cellular alterations that could be behind the reduced durability of restorations in these patients. We will also discuss how these mechanisms may be interconnected and what clinical implications they have. With this, we hope to shed light on how advances in understanding these mechanisms could lead to better dental care and treatment strategies for patients with cheostomia. Right now is a health problem with a prevalence of 22% of adults, which includes xerostomia, a feeling of dry mouth, such as hypersalivation, reduced salivary flow. The diagnosis is established by 0.1 milliliters per minute of unstimulated saliva. It must be understood that although xerostomia and hypersalivation are related, they also occur independently. The most obvious causes of dry mouth are Sjogren's syndrome and radiation therapy to the neck or head region, but a more common cause is medications, especially polypharmacy and sedative or anxiolytics. Age over 50 years and family sex are also associated with dry mouth. Dental restorations in patients with dry mouth are associated with a high failure rate. So the study. The objective of this retrospective practice-based data collection study were to determine the effect size of dry mouth on tooth restoration and survival, and to compare the survival of different restorative materials in patients with dry mouth. It was carried out in Finland, and data was collected over 12-year period ending 2015. Only patients with restorative treatment were included in the study. They were classified according to the type of xerostomia and classification and its etiology. Restorative materials were classified as resin-based direct composite, glass ionomer cement, amalgam, or fixed prosthetic crowns made of gold, ceramic, or their combination. And the results, the survival of the composites was shorter in patients with dry mouth than in control patients. An additional survival analysis showed different survival curves for the composites in patients with xerostomia or hypersalivation of non-specific etiology versus patients with Sjogren's syndrome or history of radiotherapy to the head and neck region. Composite survival in patients with dry mouth was associated with size, but fixed prosthetic crowns lasted longer than all composite sites. In the case of fixed prosthetic crowns, it was higher than the of large composites in both patients with dry mouth and control patients. Class 5 fillings from patients with dry mouth survive longer than glass ionomer cement fillings, while in class 5 fillings of control patients, the survival of composite on glass ionomer cement was similar. Tooth extractions per patient were twice as common in patients with dry mouth than in the control patient. So, genomic proteomic mechanisms could influence the decreased survival of dental restorations in patients with xerostomia by altering the expression of genes related to the production and regulation of saliva, as well as the protein composition and cellular properties of the tissues. My hypothesis one is through the modification of the oral microbiota. Xerostomia can alter the balance of the oral microbiota, promoting the growth of pathogenic microorganisms that influence the quality and life expectancy of restorations. Decreased saliva production can cause imbalance in the normal oral microbiota, meaning that certain bacteria can proliferate to a greater extent. The acids produced by the metabolisms of bacteria can degrade the materials used in dental restorations, such as composite resins. When these acids come into contact with restorative materials, they can erode and degrade the surface of these materials over time. To validate this hypothesis, research will be required that analyzes the composition of the oral microbiota in patients with xerostomia and how this composition is related to degradation of dental restorative materials. Also, in vitro studies could also be performed to simulate the impact of acid-producing bacteria on dental materials and their durability. The other hypothesis is about xerostomia that could trigger a chronic inflammatory response in the oral cavity, resulting in the release of inflammatory mediators and the activation of genes related to inflammation. This change could interfere with the integrity of the restorations and accelerate their failure. Gene expression studies are suggested perform gene expression analysis in oral tissue samples from patients with and without xerostomia to identify genes that are activated in response to xerostomia. This could include techniques such as RNA sequencing, validation of inflammation-related genes, identify and validate specific inflammation-related genes that are activated in response to xerostomia. This can be achieved using real-time quantitative PCR techniques and Western blotting techniques to analyze inflammatory proteins. So to conclude these presentations, I like to say that cellular and molecular changes in the oral cavity produced by conditions such as dried mouth and xerostomia can affect the integrity of dental restorations, resulting in shorter survival times, as was visible in the study. Further research is needed to validate these hypotheses and better understand the underlying mechanisms that affect the longevity of restorations. These findings have important implications for personalized dental care in people with dry oral conditions. When informing a patient with dried mouth about the expected survival of a restoration, it should be kept in mind that the restorations and teeth of patients with dried mouth have significantly shortened survival time. So that will be all. Thank you for your attention.